Say hi to him. So I slip in the back of the upper cervical class, and I'm waiting to see Dr. Stan Pierce. And there's this little guy, and he's talking. I'm thinking, dadgum, I wasn't in the wrong classroom. And as I'm standing there listening, I'm thinking, whoa, this is cool. This is sharp. Man, this guy's good. I hope he comes back. Well, then I found out Dr. Stan Pierce Jr. So the second generation, or the junior, which is actually a fourth generation doctor of chiropractic, blew my socks off that day. So I was just thrilled that he has continued to be part of Sherman College and give of his time, talent, and treasure to the school. So as I mentioned, Dr. Pierce is a fourth generation chiropractor. Graduated in 1999 from my alma mater, Life University, only back in the early years, we just called it Life College. Board certified in Atlas Orthogonal, co-founder of Advanced Orthogonal Technique. He's the founder, CEO, and lead instructor for Evolutionary Percussive Instrument Corrections. I said that's too much for me to pronounce. He said, okay, Bob, I'll just call it EPIC for you. He's a co-designer of the next model of adjusting instruments, the Integrity Genesis, professor at Life College West. He also is one of our adjunct professors for the EPIC program, International Chiropractic Association Council on Upper Cervical Care, Upper Cervical Diplomate degree, member of the International Federation of Chiropractors and he just all kinds of stuff. The guy's got no list this long. I know most of you students have heard him before, and that's probably why you're all here. Please give a warm welcome to Sherman College's friend, and I think maybe my friend, Dr. Stan Pierce.
Good morning, bright and early, 8 a.m. Wow. Students, good job. It's your weekend. You could have been chilling out, doing something else. Instead, you're here to hopefully learn something, be inspired, maybe. I'm not up here to be an inspirational speaker today. This is a research symposium. It's my first time here, and I was actually so excited that Dr. Kent asked us to come present, and I was kind of trying to figure out what's the nature of the crowd. You got to customize your talks to your target audience, and I'm like, I've never been to IRAPS before. I've heard about it, and I've always thought, man, these guys are intellectually, they just got to be so far beyond what I could even process. It would probably just be awkward for me. And yesterday, I was like, this is really great. Like the level of speakers, first speaker started off, and we're listening. I'm like, these guys are really brilliantly smart, but they also communicate on a user-friendly level, which was very important to me to realize how does this impact chiropractic? How does this affect the future where we're going? And so, thank you for inviting me to the event, Dr. Kent. I appreciate that very much. Hopefully, something that we're doing inside our technique can encourage others. It's a difficult challenge. Also, I love speaking to Sherman, by the way. Not to be negative on any other college, but Sherman's students have a different tone to their mindset and what they're here for. I'm not sure if it's because you guys make entrance requirements harder, you can be suspended if you're slacking, but your focus on being a serious doctor, someone who can really impact the profession, impact healthcare, is very inspiring for a speaker to spend their time to come and teach you. So students, you're the inspiration for why the teachers are at the school. You're the inspiration for why the guest visitors come to speak. So thank you for having the mindset of being our colleague and changing the world with us. Running a technique is extremely hard. I've been involved with several of them, but EPIC it's kind of our mindset more so than a technique. It's a movement more than an adjusting protocol. And so the E in EPIC stands for evolutionary. So we're always trying to evolve and advance and improve it. But it's also a sensitive subject matter. When you're the head of a technique, you've got to be able to say, this is what we stand for without making other people wrong. The hardest thing in our profession is it seems like everyone wants to make each other wrong, and that's a really bad idea if we're trying to really advance the profession together. So when you hear challenging concepts, which you presented a few to me in your talk, when you hear some challenging concepts, I go, good, keep challenging. Keep challenging the standard of care, the status quo. But there is an underlying premise behind our mindset, at least, and I hope you agree, that we definitely are not responsible to heal the body. Innate's the one that does the healing. But we do have an accountability and a responsibility for something, and that is our quality of care. Bless you. The philosophy, science, and art stool that we talk about, which I kind of throw technology in there too. But that three-legged stool, often we, especially in this format, thank goodness you guys are preserving the philosophy and intertwining philosophy into everything you do, because that's what we do in Epic as well. But we also tend to see a bit of a trend sometimes in chiropractors where BJ referred to it as slipping, not really working on your craft, and being specific is not really everyone's goal sometimes in practice. It's kind of just getting through the day, getting through your numbers, helping people some, rather than giving that adjustment, that special something, that quality correction that no one else can give. It's the top of the top. You're the elite specialist in subluxation-based care. There's sometimes people don't hold that inspiration of, I've got to be exceptional because my patients deserve it. So in being responsible for your quality of care and then running a technique, you have certain challenges. First of all, we have to question, does our technique do what it claims it does? Techniques all make these claims that they do things. Well, prove it. Do we have a measurable standard of care? Or are we literally just adjusting people and making assumptions? I'm not interested in standing up here with a magnetic personality to try to convince you to believe me. You know how chiropractic works regardless of if the patient believes it. I literally love telling patients, no belief required. Chiropractic works regardless of whether you believe it or not. But inside techniques, it makes very little sense to me that I should follow what a mentor or historically relevant chiropractic leader tells me to do just because I should believe them. I should be able to challenge them. You should be able to challenge me. And how do we challenge it? We have to have some type of measurable standard of care that we can go to and say, because of this measurement, because of these standards, that's how we validate our techniques doing what we say it's doing. Can we internally scrutinize our technique to find out what works and what doesn't? What works and what doesn't? Hey, that's not fair, Dr. Stan. All chiropractic works, don't you know? Yes, and when I went to Life University, I heard this over and over and over. Chiropractic works. And I go, if they all worked the same, we would have one technique called the chiropractic technique. They don't all work the same. They all help people, but if they all work the same, we wouldn't have to have such diversity. So that's why I love diversity in our profession. We don't have to have uniformity where we're all doing it the same way, but we do need to be able to compare things. Are we willing to change our technique if the data says to? Does that make anybody uncomfortable right now? I mean, I was going to school. The number of people who said, I do it this way because it's exactly how B.J. Palmer said he did it at his volume in 1930, whatever. And I go, do you really think B.J. Palmer would be doing it exactly the same way now as he was doing it in 1930? He was incredibly progressive. I think if we're preserving his heart and mindset of advancing his profession, that we would look for ways to strategically and logically build on his work. Not use it as a crutch, use it as an inspiration. And then can we duplicate our system of care? It's one of the hardest things in chiropractic. There was a franchise group called Upper Cervical Health Centers. And they tried to put a brand out there in the marketplace with multiple clinics. And I talked to the leaders of that group, and I said, how are you going to preserve the integrity of your brand? Because you're going to have different techniques, different practitioners, different skill levels. And if a patient goes to one clinic, and then they go to a different clinic, are they going to get the same exact quality of care? And they're like, well, we expect you guys will train them up to produce that quality of care. And I said, you have a big vulnerability in your brand. Because different chiropractors adjust different ways and get different results. That's not a negative to our profession necessarily, but it is a reality. And then ultimately, how do we hold each other accountable to reproduce that standard of care? The word accountability is not a very common word I hear in our profession. I hear a lot about the excitement and the philosophy, and I really enjoy Dr. Rosa's work and things like that. Us all being accountable for our quality of care on every single adjustment we render. to every single person walking through our office, or the offices that we own, and all the associates that we have working for us. How do you know they're duplicating you? Well, the patients aren't leaving. So, does that mean they're duplicating you? When you are a magic adjuster, when your hands are gold, can you duplicate yourself? Or are you just the golden superhero? And when it comes to the students and the failure rate and us trying to preserve the integrity of our graduates succeeding in practice, holding on to an accountability and standard of care is critical for them to be able to duplicate high-quality results day one in practice. And that's the big challenge. Because we tell students, oh, you're going to need to be in practice for 5, 10, 15 years before you're getting good results. And when I first heard that as a student, I was like, so first 5 years, I'm still going to ask people to pay me to work on them? That's why it's called practice. It felt kind of dirty to me a little bit. Like, well, I need to kind of get really good now. So day one in practice, I've got a valuable product to offer the public at a high level so that I can expect them to pay me for expectable great results. We don't want that for students. So the point of this talk, and the reason why Dr. Kent asked me to come, is I'm going to be introducing you to a data mining program being used inside our technique. I'm going to reveal to you the statistical correlations that in different categories, just to stimulate thought in a discussion. And then, frankly, I'm doing this talk because we need your insight. I don't know how often it is that a technique group will come present and say, we want your feedback on how to best develop where we're going. Well, I don't practice that. Great. Then your mindset is going to be fresh and untainted. You'll have a different perspective, so please scrutinize what we're doing. Go ahead and give us some insight. That's really ultimately what we're here for. I asked Dr. Kent, I said, I want you to scrutinize what we're doing and give us some advice on where to go. So ultimately on breaks and stuff, if you have any considerations of what we're presenting, please definitely come bring them to us so we can all be learning from each other. Now the way that we received the data was we had doctors of chiropractic from 12 different clinics, collected and recorded information on over 2,300 cases. The information was recorded in a software program utilized in the EPIC technique called Sonus Blueprint. The data points of this collected information were then cross-referenced for review and consideration. And here's how the data was accumulated. So the doctor would enter the demographics, the patient's name, birthday, male, female. They then, it's a little blurry, but they then put in all the examination findings. All the findings. So whether they did range of motion evaluations, leg length assessments, Bakuda marching test, whatever, any findings they did and received, they would document. They would then document the x-ray findings, the curves, the angulation of the atlas and C2 for the other x-rays we take. They would analyze which discs were degenerated, whether there was listhesis, degeneration in the joints. They would then also document the biomechanical findings. So inside Rostic-based work, you have the idea of measuring with lines and references to get degrees of malposition. So you put all the degrees, which side the atlas went to, how many degrees, the rotational malpositions, second vertebrae malpositions, lower neck angling. We'll go into that just a little bit. But then in addition to that, inside EPIC, one of the things you may not realize about us is even though we come from an orthogonal background, we infuse the articular world's considerations. So when Blair technique says there's aberrancies, and I don't know how many they measure, EPIC says, we totally agree with you. We measure 23 genetic aberrancies per patient, finding out what is their appropriate angle. And I'll give you just a little teaser about further the talk. It's not usually orthogonal. If you know what orthogonal means, it's where the skull and neck go over each other and the atlas is perpendicular to that. For all of us to be sitting orthogonal would mean we were all anatomically identical, which is highly impossible. And so orthogonal is not the goal of an EPIC correction. We customize the adjustment for genetics as well as misalignments, and so we have to document those genetic anomalies in our software in order to be able to track and see how are those affecting our adjusting protocol. And do we need to modify that protocol based upon certain genetic uniquenesses existing? One of the other things about being a Rostic orthogonally based program is that immediately after the first correction, we post x-ray the patient. and remeasure the structural realignment compared to the pre-adjustment misalignment. Because, once again, in our technique, we have to control something. It can't be that we all study for our specific line of drive. And the more specific we are, in EPIC we say, well, at what point is specific enough? When do we stop getting more specific? And so in that specificity and in that control model, we're not controlling the healing. But there is something that we're supposed to control, something that we're just releasing with our energy. No. There's a specific line of drive all of us trained to deliver. The more specific we are, the better the results. No matter if it's hand, instrument, doesn't matter. So in diagnostic-based work, if people are measurably misaligned, with genetics considered, and then you do an adjustment that's supposed to reduce that, we are able to take a post-X-ray and remeasure the structure and see that the changes occurred, hopefully, in the way we expected. Hopefully that the patient reduced completely, and if 3/4 of it reduced, but one was stubborn, we need to know that right away, so in future adjustments, we can add extra leverage to the one that was more difficult to get that last one to also respond, so we can hopefully just get a great correction on that hopefully stays in place for a long time and people heal. So we do have the post-X-rays being added into the data points as well. Very, very important. That is one of the advantages when you say, well, hey, you're a brand new student giving a first adjustment. How do you know you did your job right? And if we have X-rays and neurologic considerations saying here's subluxation, then we adjust them, and then we can say, now here's the reevaluation of the nervous system, and here's your re-X-ray to make sure the bones are now realigned. Then it gives you a consistent pre-post criteria by which you can make your comparisons. And if your comparisons are not so great, that lets you know, gotta do some more work. So new ways of doing research. One I really enjoyed yesterday. The speakers that were here, you guys throw out so many interesting little pointers. And one of the things about we need to find new ways of doing research. I think it was in the panel last night. There was something that came up about we need to find new ways of doing research. And I remember when I was showing this information to Dr. Kent, and he was looking at all the data points and all the cross-referencing we were doing, he got very intrigued by it. And I remember when we first started with this software, it was being designed to assist students in performing EPIC. You literally would put all your information in, and it would tell you how to position the patient, how to calibrate and set up the instrument, and then you put in your post-X-ray information, it would tell you how you did and what changes to make to your protocol. So it was designed for clinical support, basically, so that and students get this for free, by the way. Once we're, Dr. Joe, once we're in your clinic with the machine and stuff, the students get this software for free. And it guides them through doing the procedure, just in case the floor doc may not be 100% trained in the technique. It gives the students a little background as to how to support them doing the adjustment right. But new ways of doing research, one of the things that frustrated us, we did have one of our doctors present at ACC RAC some years back and did a couple of case studies. But one of the things when we were looking up research was we found, like was documented, somebody talked about yesterday, that there's not much chiropractic research in the journals. Even in the box we got shoved into, the low back pain, neck pain, headache box, that we all hate the fact we got shoved into it, even inside that box, there isn't that many studies that are concretely saying, hey, chiropractors should be in the headache discussion or in the neck pain discussion. So we were looking at going, man, we just need to get more chiropractic research out there in as many different ways as possible. And so what these data points did was as we started cross-referencing, which I'll go over now, we started looking at the different correlations, we started realizing we could publish all over the place. I remember Dr. Kent saying, he's like, you literally have a limitless data set for as many studies as you guys want to do. And it hadn't really hit me until he said that. I was like, oh, yeah, we really do. So we'll go over some generic findings first. The way that the software correlates is it'll give the doctor their personal practice information compared to the cumulative clinic information. So you have the 12 different EPIC clinics. One of them was in Dubai, for example, Utah, Philadelphia, Dallas, they're all over the place. And you can compare your clinic statistics and demographics and chief complaints and performance on x-rays, how well you adjusted. You can compare that with 11 other field doctors. It's really nice because then you can see how you're doing. and areas that you're strong, areas that you're weak. But you can also look at some generic things. So in this doctor's personal practice there in Florida, they have a higher age demographic. They have an older population. Shocker, it's Florida. Everyone ends up in Florida at some point. But then you start looking at the cervical curves compared to age. This gets kind of interesting because you start to see that on average, people 0 to 10 years old, 24% of them have normal curves, 43% have reduced curves, 29% straight, 4% reversed. 11 to 60-year-olds. The reason why we opened up that target range so much is if you look at the overall numbers and run them through, you'll find out these are the averages of this age group. Only 7% of people between 11 to 60 years old have normal necks. 23% reduced, 62% straight, 8% reversed. And then here's where it gets kind of interesting. The more mature age patients, 61 to 90 years old, they have more normal necks than the 11 to 60-year-olds. Bless you. They have more reduced curves than that age group, which you might say, oh, that's too bad. No, it's not too bad because when you look at the straight necks and the reversed necks, the older population's necks are in better shape than the 11 to 60-year-olds. How interesting is that? Now, a completely unrelated piece of information is that the use of computers began skyrocketing starting in the 1990s, and people sitting with bad posture. And something else completely related to curve loss of the 11 to 60-year-olds, of course, was the texting. So, you heard the whole thing, text neck or tech neck, and somebody trademarked it and gave themselves a platform to talk about this. What if we were able to come along and say, we can statistically show that it is occurring? No, it's part of aging. No, if it was part of aging, the 61 to 90-year-olds would have worse necks. How many 61 to 90-year-olds are not tech savvy? They didn't grow up with the years of doing this. So their necks aren't as jacked up from it. They're not as damaged from it. You can see this, so we could actually take that data and start putting it out there in certain platforms. So now what about disc degeneration compared to age? Well, let's look at C4, C5 disc. The trends of it show the disc degeneration occurring between age 11 and 30. That's the primary degeneration stage of it because it continues to double in prevalence in each of the next 3 age groups. It shows to be 10 times more prevalent to have a C4-5 disc degenerate by age 51 to 60 compared to age 21 to 30. And then it seems to kind of stabilize after the age of 60. All right, what about C5, C6 disc? It shows degeneration starting around age 11 to 30. It increases 2 to 3 times per decade by age 31 to 40. And then the prevalence more than doubles over the next 2 decades. Then it continues to increase with age. So the C4-5, although it hit a point at which it started to destabilize, it seemed to stabilize its integrity after about age 60. The C5, C6 just kept getting worse, even after that age. And then C6, C7, it took a while longer before it started getting affected. It didn't seem to start weakening as much until after age 50. Then it increased pretty significantly for 2 decades, and then it kind of stabilized itself too. So it seems that the data show, as many of you know, bless you, that C5, C6 is the first one to go. C4-5 disc is the next. C6, C7 is the next in chronology. So how does anterior head carriage affect discs? Because remember, I told you, we started this off as a software to just help you implement your procedure. But then all of a sudden, all this data started coming out. So we found that the overall disc degeneration appears to increase with anterior head carriage, especially at the C5, C6 disc. It did negatively affect all the discs to have further and further anterior head carriage, which is why the whole tech neck thing matters. But it seemed to really dramatically affect C5, C6 disc. When the anterior head carriage was over 30 millimeters, that's where you really saw the discs start to drop fast in their integrity. So when you say, come on, Johnny, sit up, you have bad posture. And your little Johnny sits up tall, and then 3 minutes later, he's right back to his bad posture. Well, it's because he's subluxed. The kid's posture muscles aren't getting proper nerve supply. He can't hold his head up. So we got to get kids adjusted so they don't develop this anterior head carriage and tell them, get your phones up here, stop having your phones down here. There's legitimate reasons that anterior head carriage, adding 10 pounds of pressure per 1 inch going forward to the lower discs, it actually matters. What about listhesis? People have been in accidents, have slippages in George's line. We found that in cases with anterior listhesis, you were more likely to show a correlation in all of the discs going bad, except C6, C7, and C7, T1. They were more likely to be negatively affected with post-row listhesis. Why? I don't know. I really haven't even gotten to spend time thinking about the why. We were just looking at it going, really? So people whose vertebrae are slipping forward, the 4, 5, 5, 6 discs were going bad, but people who were slipping backwards, it was degenerating their lower discs more so. We have to think about that. Now there's something called styloid process, as most of you guys are likely aware of. It's the attachment point for that stylohyoid ligament to hold a hyoid bone. Well, there's something called Eagle syndrome. Most of you are probably familiar with. Actually, there's people with Eagle syndrome where the styloid has developed longer. And they say, well, if it's longer than 1 inch in development, it's clinically significant in their syndrome labeling. For us, it's clinically significant if the styloid has developed long enough that it's in front of the atlas transverse process. Because with a rotationally dislocated atlas, it can push the internal jugular vein to the backside of that elongated styloid and create that jugular vein compression syndrome that can affect intracranial pressure. And that's already been linked to MS, and all. And you just heard Dr. Hunt talking yesterday about different things with increased pressure, not being able to drain properly. So we found, on average, 48% of people have styloid processes that have developed long enough that it's in front of the atlas TP. 48% of the public has elongated styloids, where a rotationally dislocated atlas could compromise internal jugular vein. That's a big number. So then the question is, well, is this pathologically developed? Is this genetically developed? Well, in ages 0 to 10, we found it was not common at all. It starts showing up more in the teenage years. So it appears to be, possibly, more likely a developmental thing, where most people just have elongated styloids. Well, that moves our whole upper cervical discussion into a brain health discussion of vascular flow. It's not that we leave the neurology, absolutely not. But now we're talking about, no, legitimately, you're predisposed to mental deterioration if you leave your atlas rotated because you've got elongated styloids. Oh, by the way, one more quick thing. We actually tracked the different years that these were being observed. And what we noticed was actually when we got our doctors aware of looking for styloids, as their awareness increased, they saw it more frequently. They were missing it. Hey, 10 years ago, I was missing it. I didn't even know to look for it. I never even hardly heard about it. All of a sudden, I start seeing them. Like, what are those lines doing through there? What is that? And then you start seeing it more and more, and then you become aware. And once you see it, you can't unsee it. All of a sudden, you're like, this is all over the place. I have a whole other level to take my patient care discussions to. I know we don't talk symptoms. If you were to correlate what percentage of people with headaches that walked into Epic clinics, what percentage of them had elongated styloids? 49%. What percentage of them had counter rotations, where C1 was misaligned rotationally one direction, and C2 was misaligned the opposite, called counter rotations, which can put a strain on the vertebral artery blood flow? 35% of people with headaches had counter rotations. And then what percentage of people had the elongated styloids and the counter rotations? That was 44%. We are tracking the location of transverse processes compared to mastoids and mandibles. Why does this matter? If you're using a technique that's a transverse process contact, and that technique happens to be underneath, not inferior, but deep to the mastoid, you may have an anatomical complicator to that approach. What if the ear cartilage is developed way low? They have basilar invagination, and everything's just tucked up really tight. You may have to have another technique option to get adjustment force to go to the atlas. Maybe even putting the sound wave instrument through here to get the force to hit the atlas. We just need to see it and track it and know where to aim. That's all. So that's kind of the general demographic. Now, talking about orthogonal effects on physical exam findings. Everyone wants to know, okay, so if the right leg is short, does that mean I have a left atlas? So if I go on a missions trip, I'm trying to figure out how to adjust. Okay, so the leg was short, the back was tight here. I appreciated your study you were doing to try to see if there was an SEMG reaction to the low back muscles based upon the cervical syndrome and not finding a correlation. We kind of find the same thing, that there isn't much of a correlation there because there's 4 misalignments. It's not just one direction. So 4 misalignments can be all crazy concoctions creating different neurologic effects. So first we just started tracking certain exam findings that were kind of just a point of interest. So, the Fukuda step test, where they're marching with their eyes closed. Well, almost 100% of people will march forward when you do that test. They'll start marching with their eyes closed and then just go forward. About 40% of them will rotate to the right, about 40% will rotate to the left. Some will translate to the right, some will translate to the left. There wasn't a dramatic correlation except for most everybody marches forward. And it freaks the patient out when they open up their eyes and they're across the room. It gives you a little emotional, whoa, what's wrong with me? Boy, real out of alignment. Now, could the marching forward relate to the anterior head carriage? Very likely. The loss of curve, putting more of the weight in front of the body, and so now you're marching and going forward. Probably pretty likely. Oh, which leg more commonly pulls short? Okay, well, in this doctor's individual practice, he found that just under 60% of right legs are short. The 12 clinics combined found almost the same exact figures. How short does a leg typically go? It's being tracked. So then you start to have the orthogonal discussion, and I'm not here to teach you orthogonal work, it's not relevant, but to help you understand what we're just going to go over the next few slides. When the atlas slips laterally in an orthogonal measuring system, it'll slip laterally and create an acute angle between a line through the atlas and a line through the skull. The line through the skull is drawn through the parietal bones, a weight-bearing line through there, and then the atlas being level to that or not is called orthogonal if it's level, or non-orthogonal if it's an acute angle. So an acute upper angle, which we call the FAC, I'll just call it atlas laterality, since we may have some different people here that's a little easier for everybody. So atlas laterality is which side it's gone to. Then you have the lower angle being acute on one side, so when the atlas did misalign, is the lower neck angle going here or here. And we'll call that the lower angle, so you don't get complicated terms here. Then you have the second vertebrae being rotationally misaligned, whether the C2 spine is gone left or right. And then you have the atlas rotationally misaligned, which we'll just call atlas rotation. So we were trying to look and see statistically, how do the exam findings, do they correlate with different types of misalignments? Or is it just arbitrary? We found that 83% of the time, the right C2 DRG location will inflame more so than the left. I actually did a talk at our symposium 2 weeks ago explaining we now know why that is, which was crazy because nobody's ever known why that is. We actually now physiologically know why that is. A left laterally dislocated atlas, where the lower cervical spine is acute on the opposite side, seemed to be the one that created the most neurologic indicators. The C2 rotational misalignment didn't seem to have a direct correlation in prevalence with any of the exam factors. Meaning whether it was left or right, you didn't see much change in the actual exam outcomes, in the physical findings. Atlas rotational misalignment, called a theta Y, meaning the right anterior, left posterior, that direction of atlas rotational misalignment, that occurs 66% of the time. And did seem to affect the neurology. But then what we had to do, in order to really start getting to this whole quality control discussion, we had to start categorizing these patterns. It couldn't just be, oh, we have a left atlas with an opposite lower angle, so it's a contralateral pattern, which you'll hear in the upper cervical prostate guys. Or if the lower angle is acute on the same side, it's called an ipsilateral pattern. It couldn't just be, oh, we have a contra and an ipsi, because you have lots of variables inside of it. Was it a contra where the atlas was posterior or anterior? Those are two different situations. And when the atlas went posterior, the second vertebrae go right or left, two different considerations. So we actually had to categorize them. And so the contralateral patterns were initiated with a C in the front of them. And then we actually were able to identify there's 8 different designations of contralateral patterns. Then there's 8 different ipsilateral patterns based on the specifics. And then there's mixed patterns that aren't really contra-ipsi. The lower neck is sitting neutral, but you have other variations going on. So once those are labeled, then you get to see something very interesting. And that is, if you look at this graph right here, the red line is this individual doctor's practice and the prevalence of how often these types of patterns walk into their office. The blue line is all the clinics combined and the prevalence of those case types walking into their office. And you see the lines almost follow each other exactly. I remember when I showed that to Dr. Kent, he goes, now that's fascinating. And you could see this from Dubai and from all over. You had this prevalence of case types showing up in offices. 45% of people showing up were contra patterns, 32% were ipsilateral patterns, and 23% are called the mixed patterns. So now we get into a fun segment. And by the way, there's lots more cross-referencing we can do. I mean, a ton of cross-referencing. Literally, it's just data inquiries because the data's already there. You literally just ask the computer now, hey, compare this to this. Hey, compare this to this. And you can just keep coming up with more interesting information. But this segment right here is one of the ones that I personally love because one of the things we try to do in EPIC is challenge the status quo. We want to challenge our mentors, the concepts we've been taught. We really want to start to see what shows up as logical to us. Because there's a youth movement that's going on inside chiropractic that y'all's minds are so innovative and fast and creative and challenging, and you want to move forward together, that it's not about that person said something, so I'll just do it because they said it. In fact, more often this generation has a respect issue of their elders, or they may not respect elders as much as they used to. So a couple of basic things we looked at was, well, what angle is the atlas typically sitting at? So we have a way we draw a line through the atlas on the sagittal film, lateral cervical, and we document what degree that line is at, so we can take our next x-ray shooting through that angle. And then we document which facial feature to aim the central ray through. And just out of points of curiosity, we were able to figure out that approximately 60% of the nasium/frontal films that are taken could be taken through the bridge of the nose with about a 13-degree tube tilt. And you'd be able to see most people's atlases within a 7-degree tolerance for studying the x-ray. So if you were going to mess up and not customize your x-ray angle per patient, well, put it at 13 degrees and shoot it through the nose, and you're 63% of the time going to get usable film. The C2 vertebrae. We actually take an x-ray to measure the surface of C2, and we do basically the same thing. And we found 63% of APOMs could be taken at a negative 2-degree tube tilt, shooting through the open mouth, and you'll pick up the surface of C2 within a 7-degree tolerance. And the reason for 7-degree tolerance is because in the Grostic work, part of your leverage angle for the adjustment is you're moving the atlas through the condyles and the C2 curvatures. So you have to be able to view those curvatures as accurately as possible. Within 7 degrees, you'll get the accurate C2 curvature measurement. Once you're beyond 7 degrees, you get a skewed measurement. So then we start looking at something basic, like what is the curvature of typical condyles? And we found that it's between a 3 to 5 inch diameter circle curvature, which that won't mean much to anybody in here, but if those of you who have studied upper cervical work and learned under the Grostic work or the atlas orthogonal work or things like that, people sometimes make statements. Well, the curvature of the condyles is always 3. Just go with 3, it's fine. And a generalization begins to occur. You start to see statistically, hey, you know what? A good portion of the time it is 3. But if you're not a 3, and I adjust you with the assumption that you should be a 3 because somebody said you should be, then I'm going to be error. I'm not going to be accurate for you. The axial surface we found was steeper. It was between 4 to 8 degrees. 4-degree diameter circle for the C2 surface, so it's a bit flatter. And then let's go into the big thing. So this is where, if you're an orthogonal practitioner in this room, your feathers might get ruffled a little bit. I'm an orthogonal practitioner ruffling my own feathers because this is healthy for our profession. It's just to look at this and say, orthogonal is the right position for everyone. Genetic anomalies are occurring. And I have tons of Blair friends, and they're like, no, orthogonal is impossible. There's so many genetic anomalies. Are you kidding me? And I go, no, you're absolutely right. So one of the most basic concepts of genetic anomalies that throws off the orthogonal interpretation is the fact that if the bottom of the skull, which is actually touching the atlas, the condyles, if the plane of the condyles is 90 degrees to the rest of the skull, then the atlas, when in good alignment, could be 90 degrees to the rest of the skull. But if the condyles are not 90 degrees, they are genetically tilted. They just formed this way. Then if that person is in their neurologically neutral, innate built position, the atlas has to match the condyles, which means it cannot be orthogonal if the condyles are aberrant. So this is showing you an observation of, for example, when the plane of the condyles is aberrant. 38% of the time, the condyles are aberrant. 38% of the time, just looking at aberrancy of the condyles, orthogonal is not the goal. The condyle is high on the side of atlas measured laterality 80% of the time. But here's where it becomes really funny. How many times do you have somebody in the articular world, a knee, chest, or Blair procedure, arguing with the guys in the orthogonal world saying, no, look at the atlas overlap. It's obviously a right listing on the side of the condyle. These guys are saying, no, it's measuring orthogonal on the left. 17% of the time, in cases involving aberrant condyles, it changes the perceived side of laterality to adjust on. So that actually ends up being about 7 out of every 100 cases. So here's the deal. It's very easy to explain. We'll assume a straight up and down center line for the skull's center of gravity. And if the condyles are genetically tilted 1 degree this way, so watch closely, if it's 1 degree tilted this way, but the atlas has dislocated, we'll say, this direction. So we'll say, let's actually make the condyles, we'll make the condyles 2 degrees and have the atlas misaligned 1 degree this way. So keep in mind, the condyles are 2 degrees tilted like this. Atlas matching it would be 2 degrees, but it misaligned this direction 1 degree only. In the orthogonal world, it's going to be acute on this side 1 degree and need to be pushed from the left. But we just animated an atlas that misaligned to the right 1 degree. But because the condyles are 2 degrees tilted, orthogonally you'd adjust from the left, articularly you would adjust from the right. Unless you measure the aberrancy of the condyles and its impact on the orthogonal work, and guess who starts agreeing? The articular world and the orthogonal world. Because you took into consideration the aberrancy of the condyles. Some people talk about, well, the atlas always goes high on the side of laterality. Some people make this statement very emphatically and talk about always adjusting the side of the higher plane line because the atlas goes out and around the condyles. We found in this study, 70% of the time, that's correct. 70%. What about asymmetrical atlases? In the typical Grostic work, you would drop a line through where the posterior arch intersects the lateral mass, and you draw a line through there and say, that line represents the atlas. And we're going to compare that line to the skull line, and that'll tell us how to adjust people. But you can look at the top of the atlas, the superior tips. You can look at the inferior tips. You look at the inferior arch, superior arch. This is the prevalency times where they're aberrant. Unreliable. So if you're not measuring to see if they're a reliable piece of anatomy or not, you could be studying a genetic anomaly claiming it's an anatomical constant. And it could throw off your entire adjusting procedure. Looking at the atlas through the top, you have the same basic interaction where you have the neural canal, anterior posterior tubercle, you have 90 degrees to that. You have a line, typically in the Grostic work, drawn through the transverse foramen, representing the atlas horizontal plane reference. You could look at the anterior and posterior borders of the superior massive atlas, and you could even look at 90 degrees to the neural canal. But look at the aberrancy percentage. Transverse foramen, which was always the Grostic base point, 11% of the time it's aberrant, meaning don't use it. The neural canal, 13% of the time is aberrant. Well, my Blair friends are all about that. I mean, I looked through the manual. Talk about, man, these atlas neural canals, they're all misshaped. Yeah, they're right. The masses, the actual articulations that touch the condyles, the weight-bearing joint part, is the least aberrant. Well, that makes sense, because it's the weight-bearing portion matching the condyles. And so if we're going to have variations, innate's smart enough to make it match the condyles. So if you were going to use features on the patient, which ones would you use? Well, whatever's the anatomical constant for that patient. So now we get into the last part, which is the main thing that inspired Dr. Kent, and that was quality control assessments being done inside Epic. How do we get students duplicating a standard of care? How do we keep ourselves from slipping? How do we know that we're adjusting people and keeping that quality up at all times? A question was asked yesterday in your panel. What are the gaps in what we're measuring in practice? I think one of the big gaps is we're not measuring ourselves to see if we're keeping our quality up. I think people are slipping left and right. Nobody wants to talk about it. Now, people obviously can get better with age, like fine wine, more experience, but is your technique slipping? Are your doctors slipping? Are you slipping? Another comment was made that we need youthful exuberance to grab a hold of this. Well, in my opinion, that means we have to have students inspired towards high-quality work and holding themselves accountable to produce that. So inside the data tracking program, this is basically what the data ends up looking like. It's a clinical guide as to how to adjust people. It'll tell you the customized biomechanical patient positioning to do. It'll tell you the instrument calibration to do. It'll give you assistance in targeting where that person's atlas is. It'll also rate the misalignments with how much is the patient not orthogonal and how much is the patient's misalignments outside the normal range of motion. That's how it's measuring these things, okay? Because you have to have a metric of some kind in order to be able to compare your pre-post data. And that leads us into talking about breakthroughs. Every single technique is having breakthroughs all the time. Nobody knows it. Because how could you know? For example, if Dr. Rossi, in his practice, if he's having breakthroughs in his technique, and he's got colleagues practicing the same technique, how will they know that he's had a breakthrough? Well, because he shows up to a seminar and says, man, my adjustments are going great. And they go, mine are too. We're all great. Yep, every chiropractor is the best, and all chiropractic works. No. My friend has had a breakthrough. How come nobody knows? Because there's no measuring there. There's no way of statistically seeing it. And every one of your techniques is having breakthroughs in the field, and the core organization may be clueless from it. I remember one of my friends went through the NUCA certification, and he used a different headpiece support than the rest of the certified NUCA doctors. And they said it couldn't be done, and he quietly, secretly did it. And I was like, good for you, man. Challenge the status quo, prove something could be done. Yeah, they didn't like it. Because it didn't fit the mold of the technique. But if you can have those breakthroughs statistically being measured, well, in Epic we can. Because what happens is, when you're tracking your data and you're comparing your data to the rest of the clinics, you can see how well are you reducing misalignments, what's your average percent of reduction, each case type, how much are you reducing things, and how does that compare to the rest of the field? So if you're looking at your statistics and you see, hey, in this particular case type, my results are way down here. I'm not reducing it as well as the rest of the field is. Because this shows you your reductions compared to everyone else's. And I can say, oh man, in those case types, I need improvement. I need to go train on that and find out what I'm missing. I'm missing some information. But then you can look and say, oh, but in these case types, man, I am killing it. I am doing awesome. In fact, I should go talk to the leadership. I've had a breakthrough. Students, what if you're the one, as a brand new doctor, that has a breakthrough? Oh, come on. They need 5 to 10 years before they're any good. You don't listen to the newbies. What do I mean? The newbies have fresh minds, fresh perspectives, and they're smart. What if the youth movement finds a breakthrough? Learn from it. Don't be intimidated by it. Embrace that fresh mind that might be bringing innovation to the forefront right away. This software itself was designed by a student trying to get better at their results. It was one of you, it was a student who actually brought this innovation into our technique. So here's what the doctor will actually see in its details. I won't go over all the little intricacies, but I will tell you this. What happens is the doctor themselves can see the case type. They can see the number of cases that they've had of that case type. When you see it in pink, that means you haven't really had many of those case types, so your data is not really solid data yet. But it does still make you aware of how you did in that case type with your other reductions. If it's in yellow, you're getting more case numbers. If it's in green, you've had a substantial number of cases that your data is more legitimate. So it kind of tells you up front, hey, don't freak out if you're seeing bad data on one case. But if you're seeing bad data on 29 cases, this will show you individually which misalignment. This is the upper angle, this is the lower angle, this is the atlas rotation, this is the second vertebrae's rotation. It'll tell you how your reductions are compared to the rest of your colleagues of those case types. So if you're reducing the upper angle brilliantly, but struggling with some of the lower angles, then you need to change your protocol. You need to get some coursework because other people are outproducing you in that area, and you can learn more. And you could be better for your patients. So if we could standardize our clinical outcomes, then we can actually start having the discussions that we've not wanted to have in this profession. Because the problem with having discussions of which technique is impactful in a certain case type compared to how another technique would have affected that case type, those discussions usually are all about your belief in your procedure. Not about your comparable outcomes and how your outcomes are to those outcomes. So that's why I've had to talk shit. The egos, and I don't want to be wrong. Don't make me wrong. Please don't make me wrong. Because then I can't be around you if you make me wrong. That's why you never talk politics, religion, and chiropractic technique. Because we don't want to make each other wrong. Well, let's not make each other wrong. Let's look at objective data, and hey, I'll show you mine if you show me yours. And you're going to find, like there was a talk yesterday by the CVP doc towards the middle of the afternoon. I went up to Matt and I was like, oh, that's awesome. We are so on the same page. I showed him this. He's like, oh my gosh, we became besties, like right away, because he has objective data, and so do I, by which we can compare how things are reducing, or prevalencies, or things like this. So the intention behind our technique is we want to use mathematical observation, statistics, to observe a standard of care to which doctors can hold themselves accountable. We then want to equip new doctors. Our biggest passion, frankly, it's not the field doctors. They're already succeeding. They're already changing lives. And frankly, they're already grooved in their method of helping people. And that's great. We're more concerned about getting the students successful within that first 5-year window. Because if they make it past the first 5 years, they're going to be okay. So our primary objective is we want to equip them with an understanding, a training, and technology to generate measurable, high-quality patient outcomes day one in practice. Then we want to develop a scientific platform that can evaluate the efficacy of our procedure, help us to change. I will tell you transparently, we've already changed a couple little things in our procedure based on the statistics. We're like, you know what? So-and-so told us to do it a certain way back in 1970. We've all been doing it that way. Look at the stats. They show that is not right at all. We've got to change that in our procedure because we're not reducing things like everyone says we are. And you tweak your procedure. How many people are willing to refine their procedure based upon what the research is showing rather than, no, I don't want to disrespect the mentor. I don't work for him. I work for my patient. And if we're creating the future of this profession, we have to look forward, not back. So we should be challenging pretty much everything with the intention of getting better for our patients. And then the other intention we have is we want to discover conceptual or technological breakthroughs occurring in practices around the country, around the world, and to develop a chiropractic community that's constantly learning and growing together while improving patient outcomes. So one of the other things we discussed with students last night was EPIC's one of the upper cervical procedures that does not outlaw full spine adjusting. I don't know how to politically say that anymore. You know what I mean? The upper cervical community really outlawed it, made people wrong if they want to check or adjust anything else. And EPIC does not stand in that position of hierarchy. We say, look, when it comes to the brainstem, please don't screw around. Please be gentle, please be accurate, fix it really well. There's just too much importance right here, and there's full spine effects from that, as well as brain effects from that. So don't be careless with brainstem. Let's be as specific as you possibly can be. Once that's clear and holding and the spine's untwisting and responding, if everything else goes away from that, great. Wonderful. Way to go, Indy. If there's other things that are still lingering, if there's other secondary subluxations, you're not wrong for going in there and fixing that as a chiropractor. So how about this? What would it be so interesting for us in EPIC if we're correcting this with the same exact measurable standard? We can see it statistically on pre-post x-rays and measure this standard. And then what if we were then measuring patients' holding patterns? And what if in 12 different clinics, one doctor is using activator as his secondary protocol? Another doctor is using diversified as their secondary protocol. Another doctor is doing nutrition in their practice. Another doctor does only EPIC and doesn't touch anything else. What if we can look at the holding patterns, comparing that with, did we fix the upper cervical spine the same way? Good, we all fixed it the same way? Great, now let's see. Is your secondary work creating better spinal stability in the upper cervical spine compared to my secondary work? Or my lack of secondary work? Oh, now you've really just opened up a massive can of worms. Because now you're talking about techniques actually being applied in coordination on a patient's case for actually the patient's benefit? How much fun is that going to be? So when D.D. Palmer says, chiropractic is a science just so far as it is specific. Please just remember, we always will ask you, at what point is specific enough? One of the other phrases we use in EPIC all the time is, compared to what? Oh, doc, we've been getting great adjustments. We don't need to upgrade into this technology. Oh, you've been getting great adjustments compared to what? What do you mean? I've been around a long time. Oh, that's a very good answer to a very different question. What are you comparing your results to? Well, I'm very happy in my practice. Good, I don't want you to be unhappy in your practice. So maybe challenging yourself is not what you're interested in doing. But we find that the biggest inspiration, the biggest passion, is looking to see what we can develop for the future of this profession. Not saying we've been good for so long. We've been amazing for so long, not just good. Chiropractic has been amazing for so long, and we can get better. And the only way we get better is if we can measure things, prove them, challenge each other, and then be humble enough to say, hey, show me yours, I'll show you mine. Let's just look at the data. And by that, hopefully, the chiropractic profession actually humbly, in a servant's mindset and spirit, can come together and just say, all right, you know what? I'm really sorry I made you wrong for doing full spine work. Actually, it's quite helpful. It actually helps our patients hold better. Or, frankly, there was a doctor who was practicing activator in student clinic, and once he incorporated EPIC, he had to do less activator adjustments. Great. In fact, you know, Arlen Furr, what's his name, Dr. Furr? Mm-hmm. He actually wrote a document to Life West with us saying it's okay for people to practice EPIC and activator in coordination with each other. But two technique heads saying, yeah, it's okay. Students can practice these two side by side. Well, that's profound. I thought we're all supposed to make each other wrong. Nope. Unity can come together in chiropractic, but it's really going to be more likely to occur through measurable outcomes versus the egos of trying to hope we can find enough humble leadership. You've got to be able to measure it so that your numbers don't lie. The numbers just don't lie. Thank you.
I have one. So when you describe the database of information that you have, my big question is, when you realize you had something bigger than what you thought you had, in your training, when you think about what you can do with this, what is the biggest thing you ultimately think you want to be able to do with this thing?
Thank you very much for asking that, because that's the fun part. That's the really fun part. It's not just about developing our technique. That's way too small of a vision. It's about We need to get chiropractic all over the place in the science community. It doesn't have to be that we're, what if a study comes out showing, hey, here's the prevalence of disc degeneration, C5, C6, you know who's dominating that discussion? Chiropractors. Oh, hey, you know how anterior translation's affecting this? This is why MVAs, car accidents, have a degenerated component. Who's talking about that? The chiropractors. You can then, even genetic anomalies, even prevalence of headache, you can start to take this and push it into so many different types of journals that we can get our exposure that we need as a profession. And eventually they say, man, the chiropractors sure know a lot about all this stuff. And maybe they are the spinal experts. And then when we propose, here's what subluxation is. It's just a natural sequelae of their trust and confidence in us because we're already the ones that dominate the marketplace on the spine. Any questions? Thank you.
So that's one of the reasons why I really enjoy coming to and participating in IRAPS is it's not, I've been to research programs where it's very, I said pointy, I call it pointy-headed research types. It's here's what we did, but I really enjoy okay, well, what can this really open up for the future? What do you see 30 years down the road doing as a result of what you've experienced with the research or the information that you currently have? So thank you very much, Dr. Pierce.